Hello, welcome to our Flourish Connect training on diversity, equity, and inclusion in nursing homes. My name is Barbara Gordon. I am the Director of Community Engagement at the Traeger Institute, and I'm happy to be here with you today to provide this training. So today our goal is to discuss how to foster equity in our nursing homes, how to foster, I'll say, diversity, equity, and inclusion in our nursing homes. So why are we discussing diversity, equity, and inclusion within our nursing homes? Why is this an important topic? So we know over the past few years since the pandemic unfolded and significant social and racial unrest reoccurred in America, significantly turbulent times, the need to expand diversity, equity, and inclusion, or DEI, into mainstream culture has come to the forefront. The realization that we have not done enough has been recognized by many industries, including healthcare. But what does all of this mean? Diversity is the presence of differences within a given setting. It can describe differences in race, ethnicity, gender identity, sexual orientation, age, socioeconomic class, religion, language, disability, political perspective, and more. Equity is the act of ensuring that processes and programs are impartial, fair, and provide equal possible outcomes for every individual. And inclusion is an outcome to ensure that those that are diverse actually feel and or are welcome. I'd like to also offer a definition for disparities, as health disparities often is the outcome when inequities exist in our healthcare systems. Healthy People 2020 defines a health disparity as a particular type of health difference that is closely linked with social, economic, and or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, based on their religion, based on social economic status, based on where they live, gender, age, mental health, cognitive and sensory or physical disability, based on so many things, including sexual orientation and gender identity, or other characteristics historically linked to discrimination or exclusion. Although the term disparities is often interpreted to mean racial or ethnic disparities, many dimensions of disparity exist in the United States, particularly in health. If a health outcome is seen to a greater or lesser extent between populations, there is disparity. If what your race or ethnicity, sex, sexual identity, age, disability, and more all contribute to an individual's ability to achieve good health, it is important to recognize the impact that social determinants have on health as well. Health disparities exist in long-term care, as well as in the community. Disparities in healthcare typically result from the interplay of insurance, healthcare access, health literacy, cultural disparities, and geographic distribution. Residents in the nursing home complicates the situation since it introduces facility differences, regulations, and even payer sources. All of these things can influence disparaged practices and care that's provided to the individual. The historical impact of systemic and structural racism continues to affect the health of many marginalized groups in America. Knowing the history of systemic racism in healthcare is necessary to achieve equity. Systemic and structural racism are forms of racism that are pervasively, and deeply embedded in and throughout systems, laws, written or unwritten policies, entrenched in practices and established beliefs, and attitudes that produce, condone, and perpetuate widespread unfair treatment of people of color. Its historical context continues to impede health equity for all people today. So I want to talk to you about some things that we've learned, issues surrounding equity and COVID-19, some things that have, I think, helped to catapult us a little bit further in these discussions about diversity, equity, inclusion, about anti-racist systems of care, healthcare systems, anti-racist nursing facilities, mind you. And you can see here in this particular slide some information that I'm going to elaborate on a little bit further with some other data, but 2021 statistics show that 5% of COVID-19 cases and 36% of COVID deaths were in nursing homes. That's quite a bit. Those nursing homes serving populations significantly composed of African Americans and Latinx patients have been twice as likely to face a COVID-19 outbreak compared to facilities with a majority white population. And as research and evaluation continues, there are a number of things that have been exposed to help us understand why there is such a differential in COVID-19, its impact on different nursing facilities, in particular populations within those nursing facilities. Investigators with Columbia University School of Nursing found that COVID-19 infections were 13.6 percentage points higher in nursing homes with 50% or more Black residents, and deaths were 3.5 percentage points higher compared with nursing homes with no Black residents. Among nursing homes included in the study, 3,639 or 31.4% had no Black residents, and under 20% of residents were Black in 1,020 or 8.8%. Black residents accounted for 20% to 49.9% of residents and 1,586 of these nursing homes. And then 50% or more residents were Black in 681 of these nursing homes. And race was not reported in 4,661 or 40.2% of these nursing homes. COVID-19 infections were 13.6 percentage points higher in nursing homes with 50% or more Black residents, and deaths were 3.5 percentage points higher. Stone attributed the disparities to structural racism, saying that nursing homes that have a high percentage of Black residents have fewer resources, poor staffing, worse infection control processes, and a higher dependence on Medicaid, with fewer patients on Medicare. And as we know, a reality that we deal with on a day-to-day basis, that the differential with the Medicare and Medicaid payment is very, very instrumental in terms of resources available to nursing facilities. As you can see here in this slide, nursing homes that rely on Medicaid payment rates, which are lower than Medicare and private payers, have long struggled with the interlocking challenge of financial insecurity that in turn undermines professional staff recruitment and capacity. That, of course, impacts the care that's provided to the residents of those nursing facilities. Across the United States, nursing homes with lower staff to resident ratios are more likely to serve Black patients. Furthermore, more severe quality programs were experienced by nursing homes that disproportionately serve Black residents. So all of these structural and systemic issues have implications for both residents and staff. The impact of these structural issues, the systemic racism that exists within our healthcare systems just overall, they affect the residents, obviously, but they also affect the staff of our facilities and healthcare institutions across the country. So Martin Luther King stated the following: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Is the American healthcare system inhumane? Is it inequitable, unjust? Does it not address diversity? Is it not inclusive? We know that we've made progress in many areas, including in the space of diversity, equity, and inclusion. But we have so much further to go, and the data and outcome data that we can see as we evaluate our systems and evaluate health outcomes of various populations help us to know that, help us to understand that our system currently has significant inequity and disparity. What does the current data about health inequity and health disparities in long-term care mean for us today? How does that data influence us in terms of moving towards change? So I want you to recall the 4 M's. Many of you have learned about the 4 M's. This has been shared with you often, and we're going to talk about the 4 M's in this framework from the perspective of how it aligns with an anti-racist framework. So the experiences of systemic racism in healthcare in America, including nursing homes, highlight the ongoing need to address and eliminate racial disparities in healthcare access and outcomes, particularly for older adults who are exceptionally marginalized due to the intersection of race and age. To effectively move towards change in the healthcare system, comprehensive and sustained effort to eliminate discrimination is required. The underlying structural barriers in the system that limit access to care for communities of color and older adults must be challenged and ultimately eliminated. So as we consider diversity, equity, and inclusion, we must consider an anti-racist framework for transforming our healthcare system, including nursing homes. Utilizing an anti-racist framework is necessary to confront systemic racism in healthcare. For example, an anti-racist framework has been utilized for several decades in the field of education for the purpose of dismantling racism through curriculum development. Some of the key elements of an anti-racist framework include building foundational awareness, expanding foundational knowledge on anti-racism, and embedding anti-racism education into practice, as well as dismantling oppressive structures and measuring progress. The fundamental components of this framework can be applied in healthcare education. It can be applied in professional development. And obviously, it could also be applied in professional training and practice. As indicated in the article, A Framework for Developing Anti-Racist Medical Educators and Practitioner Scholars, creating an anti-racist learning and work environment is critical to achieving and maintaining inclusion, increasing workforce diversity, and promoting health equity for patients. The transformational change that is needed in the American healthcare system, the transformational change that's needed in many of our nursing facilities will require a commitment to infuse the fundamental principles of anti-racism in its policies and practices, influencing cultural change within organizational structures and environments. So the age-friendly health system framework is a set of evidence-based guidelines developed to improve the care of older adults in healthcare settings. The framework has 5 key components, and I'd like to share those with you. One of the components is to know and manage the patient as an individual. A second is to ensure that healthcare providers communicate effectively with patients and their caregivers. A third is to optimize medication use. And 4, ensure that older adults are mobile and able to maintain their functional status. A 5th key component of the age-friendly framework is to create an environment of care that is safe, comfortable, and conducive to healing. These components align with assuring diversity, equity, and inclusion, and an anti-racist system of care. By recognizing and addressing the unique needs and experiences of diverse populations, including those from different racial, ethnic, and cultural backgrounds, as well as those who are marginalized due to socioeconomic status, gender identity, sexual orientation, and other factors. An example of how the anti-racist framework and the age-friendly health system framework aligns is indicated in the age-friendly health system framework's first key component, which states professionals are to know and manage the patient as an individual. This emphasizes the importance of understanding each patient's unique needs, each patient's preferences, their goals of care. And this is reflected in one of the 4 M's, what matters most, as you can see here in this slide in the top left quadrant. To take into account what matters most to a patient, healthcare providers must consider culture. They must consider the cultural, social, and other factors that influence a patient's health outcomes. And in order for the healthcare provider to be age-friendly, they must view the patient and the healthcare they receive through an anti-racist lens, desiring that they receive the highest quality of care, not only regardless of, but also tailored to their unique needs, their values, their preferences, regardless of, again, their race, ethnicity, gender identity, sexual orientation, geography, etc. So, how does diversity, equity, and inclusion fit in age-friendly health systems framework, in the anti-racist framework? Let's look a little deeper. And as you look at this particular slide, we want you to consider a few things. First, as we consider application of the 4 M's in long-term care, it is important to emphasize that the 4 M's is not a program, but a shift of care, a shift in philosophy, a shift in mindset. When we talk about looking at a patient or the services that you're providing, the care you're providing through an anti-racist lens, that truly is a paradigm shift in terms of our mindset and how we think about the care we're providing. It is a shift in how we provide care to older adults. There are 2 key drivers to age-friendly care: knowing about the 4 M's for each older adult in your care, the 4 M's that we just looked at and talked about, what matters most, mobility, medication, mentation. And this requires assessment. And then incorporating the 4 M's into the plan of care accordingly. And this requires action for us to act on. If you look at the slide again, you'll see age-friendly health systems connect to assessing and acting on. Knowing about the 4 M's for each person that you serve and incorporating that into the plan of care for that particular individual. Both must be supported by documentation and communication across settings and disciplines. Inherent in the 4 M's is diversity, equity, and inclusion, and the concept of an anti-racist practice. How can you know what matters most to a patient without considering who the person is? What is their culture? What is their lived experience, and more? So as we look at diversity, equity, inclusion, for diversity, we're considering the uniqueness of each patient. As we consider equity, we're facilitating the attainment of the highest level of health for all people. And inclusion, we're assuring patients feel valued and like they belong, assuring they have a voice, assuring the presence of a diverse healthcare staff. So think about and consider your own nursing facility, your own healthcare system, your own primary care practice where you work, whatever part of the healthcare system, the healthcare industry that you are operating and functioning in, and make application as it relates to an age-friendly health system and an anti-racist system framework. So how do we create change in our nursing homes? I'm going to provide for you a strategy that has been utilized at the Traeger Institute Optimal Aging Clinic. And this strategy is not complex, but it is definitely actionable. And it really helps us to understand that this journey begins and continues. It's not stagnant. No matter where you are in terms of considering diversity, equity, and inclusion, In considering an anti-racist healthcare system, no matter where you are in that journey, it will always continue. It's not something that we can ever stop. The American healthcare system, including long-term care, has experienced many advancements. So we know and understand that we are moving forward. We have moved forward and is much improved than it was 10 years ago. But we know also that it is still in need of much transformation, especially as it relates to diversity, equity, and inclusion. This requires acknowledgement that change improvement is needed. It requires action, intentional and deliberate, to effectively facilitate change. And it requires accountability to assure that we never become satisfied or stagnant, accepting status quo or mediocrity when it comes to assuring that all citizens of our communities receive the best health care available. So part of acknowledgement includes understanding where you are currently, which requires honest assessment and evaluation of yourself, of your organization, of your policies and procedures, etc. It requires open acknowledgement of commitment from leadership to work together to influence and impact change. It requires action. And this quote uh, supports and helps me to recognize the importance of acknowledgement. And it just says from Peggy McGuire, to transform healthcare, we must acknowledge the trauma of systemic racism and work together to solve it. And that is really what we want to do. We want to transform our healthcare systems. It requires intentional and deliberate action. This reality is not easy to accomplish in very complex organizational structures, which many of us exist in. One of the first actions that's necessary is for leadership in these organizations to acknowledge the existence of these complexities and understand how they impact the staff with a goal to advocate for change, and how they impact patients too with a goal to advocate for change that will move us closer to becoming an anti-racist organization. And yes, these two quotes are pretty sharp. They're pretty, some will even say that they sting a little, but it is really to help us to understand that in a racist society, it is not enough to be non-racist. We must be anti-racist, thus that term. And that helps us to understand that we're always evaluating and assessing, not just ourselves, but the systems where we work to demonstrate the intentional and deliberate action towards moving in this direction. And the heartbeat of racism is denial, and the sound that heartbeat is, I'm not a racist. So many of us may think, well, our facility, our nursing home, our primary care practice, wherever it is that you exist, is not racist. You may even say, well, we don't have people of color in our community and don't serve them. There may be a number of things that we can say, but remember, when we're talking about an anti-racist system, when we're talking about diversity, equity, and inclusion, it is not necessarily just about the color of a person's skin or their ethnicity, but it's about all of those differences and variances that I've shared with you earlier. So the intentionality and deliberateness of action is really, really important. Becoming an anti-racist nursing home is not a static achievement. It is lifelong work that you and your colleagues, that all of us must commit to each and every day. We believe that it is really, really important for every aspect of an organization, their mission, their vision, even the model of care, to be inherently anti-racist, but is often hindered as a result of the racist organizational infrastructure, the racist policies, whether federal, state, or local, systems of care, et cetera, that we talked about earlier. All of these things could potentially hinder or influence or affect your desire to intentionally and deliberately act to change your organization, your organizational structure. But becoming a truly anti-racist organization will require perseverance and a lifelong commitment by leadership and all staff to continue to move in this direction. And this is just a strategy for helping us, for facilitating moving in that direction, moving towards an anti-racist, be an anti-racist organization, an anti-racist healthcare facility, an anti-racist nursing home. And first, let's look at this list of things that can be done to be actionable in this space. As the work begins and continues, there are things that must occur and be incorporated in the process to meet any level of success. This list represents various intervention strategies that can be used to influence organizational change towards an anti-racist organization and healthcare system. First, you have to define the problem. You must have clear goals. Clear goals cannot be set without defining the problem that exists within the organization. This is not a stagnant step, but is fluid. It's a fluid process that can utilize various tools to facilitate addressing racism at various levels. There are many organizational anti-racist diversity, equity, and assessment tools available to facilitate identifying the problem. I would encourage researching, looking for, and accessing some of these tools to review to see which one may be useful in your own work environment, in your own nursing facility, or wherever it is that you are working in the healthcare system. We cannot mince words, but must call racism what it is. It's racism. We must call oppression what it is. It's oppression. And these tools can help you to see where policies, procedures, etc., might have a disparaging impact on the people that you are serving. You must have leadership buy-in. Without buy-in and commitment by leadership, change cannot occur. So incorporating explicit and shared anti-racist language into your policies and procedures and practices, et cetera, after your review is really, really important when you are, after you actually do your assessment and identify areas and levels of problematic language, et cetera. And as I indicated, establishing leadership buy-in and commitment is definitely a necessity. And then the resources that we put towards making these changes, yes, funding even. Funding and resources, we must dedicate specific funds for serving marginalized communities, setting time aside where clinic is, or your staff are able to come together. So the funding and resources is not just money, but resources could also be time, the time that you pull people together or give opportunity to make sure that they have the knowledge, the skills, et cetera, to practice through an anti-racist lens. And then bringing in the right support and expertise, acknowledging and understanding when you can't do it yourself as an organization, that you might need to bring in others who are more skilled, who are more informed in this space, who can be an objective influencer of change in your environment. It's important to utilize skilled consultants and trainers to support staff as well as your organization, and particularly to support leadership. And then establish ongoing meaningful community and patient partnerships. It's important to establish strong relationships with racialized communities, patient populations, and partners. And this is not just inside, for example, your nursing facility, but in the community where that nursing facility exists. Having real, true, relevant partnerships with community groups like churches, community organizations, et cetera, that represent the population that you serve in your nursing facility is very, very important. So those are some intentional and deliberate action steps that you can take to help influence the change that is necessary. And just to go a little further about intentional and deliberate action, remember this is a journey and the pace is sometimes slow. A multi-level approach must be used to address racism within healthcare organizations. Sustainable change does not occur with one-time intervention. We all know that probably every institution, every organization, every nursing facility has had that DEI, diversity, equity, and inclusion training. One-off training does not solve the problem. Sustainable change, as I indicated, does not occur with one-time intervention that only focus on one area or level of the organization. Sustainable anti-racist practices occur when there is intentional and deliberate action of anti-racist design at the policy level, at the organizational level, at the community level, interpersonal and individual level. A multi-level approach is absolutely necessary to really influence sustainable change. There's no quick fix. Leadership must be committed to not engage in tokenistic decisions, changes, and practices, but must utilize intentionally anti-racist intervention to influence change. At the policy level, there are a number of things that can be done within any organization to influence change as well as organizationally. But as I indicated earlier, don't forget the community level of action that needs to occur as well. Accountability. So through work that have been done, for example, at my organization at the Traeger Institute, we've committed to a number of things to influence change, but also to hold us accountable. And listed here, you can see some of the things that we're doing, continuing to do to influence change in our organization and to impact the policies, the organizational structure, et cetera, as well as our community engagement for becoming an anti-racist organization. Through our work thus far, we've committed to writing a health equity plan and health literacy plan for the Traeger Institute, focusing on anti-racist patient care through every aspect of our work, including educating the clinical care workforce, provision of clinical care, research, and innovation. To do this requires continued advocacy and speaking truth to power when necessary, which is not always easy, but always necessary. We must also continue to review and assess our progress and lack thereof, challenging each other to stay true to our goal to be an anti-racist organization. There are various examples of acknowledgement, action, and accountability that facilitates change in the right direction in long-term care. And I'd like to just share a little bit with you in terms of where you can find some of this information. As a nursing facility, as a healthcare organization, there are so many things that we have access to influence our decision-making and moving in this direction. The John A. Hartford Foundation and Institute for Healthcare Improvement, who started the Age-Friendly Health Systems movement, are also engaging in systems change as it relates to DEI, diversity, equity, and inclusion. They created an equity task force in 2020 and began this initiative with a focus on measures and data collection. They encourage health systems, including nursing homes, to record racial ethnic breakdown of patient populations, link collection of this data to quality measures such as admissions, length of stay, patient family experience, and more, and then analyze outcomes stratified by race, ethnicity, and then take action to address disparate outcomes. So those are some real practical steps that you can take in moving yourself, your organization, your agency, your practice, your nursing facility further into the process of becoming an anti-racist system, into the process of looking at system change as it relates to diversity, equity, and inclusion. So consider those things and definitely consider looking into the information that's available to you from the John Hartford Foundation. So putting it all together, assess your policies and procedures, create a plan for change and action, and continue to review changes and address issues So, once you have that plan, you must review it and evaluate it, assuring that you're implementing it. We will have succeeded in impacting change in the healthcare system overall and in the environments where we are working ourselves currently. When diversity is having a seat at the table, inclusion is having a voice, and belonging is having that voice be heard for everyone, not just some of us, but all of us. So I thank you for sitting through and listening to this session. Um, if you have questions, you can always reach out to us at the University of Louisville Traeger Institute. Today, the session will be on social determinants of health and long-term care. My name is Barbara Gordon. I'm the Director of Community Engagement at the University of Louisville Traeger Institute Optimal Aging Clinic. The goal of this session today is to discuss social determinants of health and their relationship with long-term care. So, what are social determinants of health and what do they have to do with nursing facilities? First, I just like to share a little bit of data with you from the county health rankings um, about social determinants of health and their impact on health outcomes. As we know, health is more than health care. In this particular information and data helps us to understand that societal factors impact an individual's health regardless of age, gender, race, or ethnicity. Perhaps the most important thing to know about societal factors is that they make up a staggering 80% of our health. Breaking that down, roughly 40% is attributed to socioeconomic factors, 10% to physical environment, and 30% to health behaviors. That means only 20% of our health is tied to the clinical care. In other words, health is more than just health care. Health is more than just clinical care. It means that we need to think and act beyond the walls of the hospital, beyond the walls of primary care settings, beyond the walls of nursing facilities. These challenges can affect anyone, regardless of age, gender, or race. So, a basic definition of social determinants of health is noted here. They are the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risk. So, just to give you some examples, here are some categories of social determinants of health. You can see here economic stability, neighborhood and physical environment, education, food, community safety, and social context, and then the healthcare system. And then some examples of types of issues, areas, constructs that are noted for each of the categories. For example, economic stability includes employment, income, expenses, debt, medical bills, and support. And just to give you some examples of how these social determinants may affect someone, I just want to share a few things with you. For example, if a person is homeless, living in unsafe or unhealthy conditions, or have limited access to food, this will greatly impact that person's health. We can also consider a recent study which found that children experiencing food insecurity may have 2 to 4 times more health problems than children from low income households who are not food insecure. And just take that example for a minute. Children who are food insecure have 2 to 4 times more health problems than children from low income households, but they are not food insecure. So something has occurred to help the low income households to not be food insecure, and their health outcomes are better than those children who are food insecure. Adults who are food insecure are also at an increased risk of developing chronic diseases such as obesity and diabetes. These poor health outcomes contribute to increased rates of readmission and noncompliance, which increases medical costs and risk. This includes even individuals who have gone into the nursing facility and who have been discharged when they have social determinant disparities, then they are likely to have a readmission to the hospital, thus going back into the nursing facility. It impacts health outcomes that hospitals and health systems traditionally care about and measure, such as quality, health status, readmissions, and value. Social determinants of health impacts who goes to the nursing home, length of stay in the nursing home, and who dies in the nursing home. Addressing social determinants of health is important for improving health and reducing health disparities. Though healthcare is essential to health, it is a relatively weak or is a less impactful health determinant. That is not to say that clinical care, that health care, et cetera, is not an important factor, an important variable as it relates to health outcomes. It's just to help us to understand that there are so many other factors that contribute to health outcomes. Research shows that health outcomes are driven by an array of factors, as I've indicated earlier, and as you can see in this particular slide, including underlying genetics, health behavior, social and environmental factors, as indicated earlier. While there is currently no consensus in the research on the magnitude of the relative contributions of each of these factors to health, studies suggest that health behaviors such as smoking, diet, and exercise, and social and economic factors are the primary drivers of health outcomes. And social and economic factors can shape an individual's health behaviors. So there's this interrelationship, intersectionality, if you might say, with all of these different health determinants. We know, for example, that children born to parents who have not completed high school are more likely to live in an environment that poses barriers to health, such as lack of safety, exposed garbage, and substandard housing. They also are less likely to have access to sidewalks, parks or playgrounds, recreation centers, or a library. And again, all of these things can contribute to our health outcomes. There's also evidence that help us to know and understand that stress negatively affects health across the lifespan, and that environmental factors may have multi-generational impacts. We also know that social determinants of health lead to premature death. They impact not only quality of life and health outcomes, but also life expectancy. For some, social determinants of health are also a predictor of where you die. As you can see here in this particular map, we know that zip code matters. We know that location matters. And if you note here, this particular data help us to understand, this is from the Institute for Health Metrics and Evaluation, that life expectancy ranges from 66 years of age to 87 years of age. And there's other literature and research to help us to understand too that there have been a significant shift in life expectancy since COVID, but generally speaking, this is the range or the variance of life expectancy across our country. And if you look at the graph on the lower right-hand side of this slide, you see that the colors indicate and help us to note or mark where the life expectancy is generally 66 years of age and where it is 87 years of age. And we can definitely tell that location and life expectancy is related. So it's been shown that health-related determinants such as some causes of death, dementia and stroke, as well as social determinants such as low educational level, significantly increases the probability to die in a nursing home. Advanced age, not having a home or a partner, low educational level, sedentary lifestyle, poor self-rated health status, high number of drug prescriptions, and functional and cognitive impairments are the main predictors of institutionalization process. A study by Hedinger et al. provides evidence that the same determinants significantly increase the probability of a longer terminal nursing home stay. Patients discharging from nursing facilities are also at high risk for higher societal determinants of health disparities, such as limited caregiver support, transportation, housing insecurity, and food access. These determinants put individuals at a higher risk of being discharged from the nursing facility and having higher hospital readmission rates. We also know that medical or care needs that they are directly related to health related factors that influence nursing home admission and stays. Social inequalities are not only present with regard to place of death, but also in the duration of that last nursing home stay before death. It's known also that there's evidence for such inequalities in both sexes. A low educational level, living alone, or being a tenant, as well. When I say tenant, meaning renting or leasing rather than owning, as well as low care level at the beginning of the last nursing home stay, can increase the risk for longer terminal stays. So again, I'm just showing you how all of these social determinants impact the activity that we have in nursing facilities. Who goes to the nursing home, how long a person stays in the nursing home. On the other hand, a high educational level, being a homeowner rather than renting or leasing, being married, having that support network, that social support, as well as a higher care level at the beginning of the last nursing home stay or a hospitalization in the last year of life decrease the risk for longer stays. If you compare this information, men and women, the terminal stay of women is on average 1/3 longer, but the role of socio-demographic factors is similar for both sexes. So literature also supports the reality that people are more likely to move out of their home into an institution if they had no social network. So having social support, a social network impacts whether a person goes into an institution, a nursing facility, or not. Older adults who enjoy going to the movies, for example, a social activity, social connection, going out to dinner with friends and family, or the casino and visiting family or friends had a lower probability of institutionalization compared to participants in or residents or older adults, sorry, who did not enjoy these activities or did not visit family or friends. So that social determinant of health of having a social network, social supports is a predictor of nursing home stay. So social determinants of health, as some of this information that I've shared with you indicate, can be a predictor of nursing home stays and the length of nursing home stays. Social determinants of health refer, again, just to reiterate, to those conditions where a person is born, grow, live, work, and age, including factors like social economic status, education, employment, social support, networks, and access to health care. And I definitely want to emphasize again that social support networks factor. Social determinants of health can influence the likelihood of someone requiring a nursing home stay in the duration of that stay. And social determinants also is a predictor of how long, whether a person lives or dies in a nursing facility as well. So it's also important for us to look at the impact of social determinants of health on nursing home staff. Research showed that healthcare support staff experience social determinants of health, like food insecurity, more than clinicians, like doctors and nurses. And that whole array of social determinants of health that I've shared with you already can be factors or um, determinants that are impacting uh, nursing home staff depending on the role that they play in the nursing home. Lower pay, lower level, quote unquote, I hate using that terminology, but lower pay, lower level staff uh, will have this, you know, the realities of social determinants and social determinants of health disparities in their life, as indicated in this particular research information from patient engagement, September 2021, that can definitely directly and indirectly impact the quality of care that residents receive in nursing facilities. So this is an area, although not necessarily one that I'm emphasizing in this particular presentation, but one that needs to be noted um, as it is a reality in our nursing facilities. So here, I just want to, address social determinants of health and indicate the fact that they not only are important for improving overall health, but also for reducing health disparities. Just being aware, addressing, being cognizant of these particular areas, they are often rooted in social and economic disadvantages, and they definitely impact how a person experience nursing facility placement, nursing facility stays, as well as whether they die in a nursing home or discharge and readmitted to a hospital, depending on the social determinant health disparities that they may experience upon discharge. Addressing social determinants of health readily will require much advocacy, policy change, and support, but can impact who, when, and how long someone stays in the nursing home. To prevent the influence of social determinants of health or nursing home placement, it's really important for us to address these determinants and implement strategies that promote health and well-being in the community. That really is where it should start. Yeah, there are things that we can do in nursing facilities as well to mitigate some of the determinants that follow individuals into nursing facilities. But if we can address the health and well-being of our community members, then it is going to impact their experience with and in nursing facilities. Some of the areas that we can focus on, for example, is enhancing access to healthcare. If we improve access to primary care services, preventive care, and specialized care for older adults in the community, this can be achieved through initiatives such as expanding healthcare facilities, increasing the number of healthcare professionals, and implementing telehealth services. Supporting aging in place. Literally, this is a goal and a strategy that is hopefully helping us to prevent nursing home placement because most individuals, as they grow older, do want to age in place. That doesn't decrease the necessity, and there is a necessity for nursing homes, whether short stay or long stay. But if we support aging in place, which will include a multitude of supports and networks of care for individuals who want to age in place, then even if they need a nursing home stay upon discharge, they will have the supports necessary in their homes so that they are not readmitted to the hospital, etc. So promote affordable housing. This has become more and more of an issue in our communities. And if we address housing affordability issues, it will prevent older adults from being forced into nursing homes due to financial constraints. So we need to advocate for affordable housing policies, rental assistance programs, and subsidies to help seniors maintain safe and suitable housing options. Strengthen social support systems Develop and strengthen community-based support systems that provide social connections, that provide caregiver support, care for that loved one, whether it's a spouse, a daughter, a son, a grandchild, a neighbor, etc. Providing caregiver support is essential to helping to mitigate social determinants of health, especially as it relates to social support networks. This can involve implementing senior centers, meal delivery programs, volunteer services, respite care options for caregivers, programs that help to reduce social isolation, etc. All of these things can help strengthen the support systems for individuals. And again, this doesn't lessen the need for nursing facilities. What it does is just help to facilitate more effective transitions of care from primary care to hospital care to nursing home care back to home. Improve income security. We need to desperately address economic disparities and income insecurity among older adults by advocating for fair wages, Social Security benefits, pension plans, and retirement savings programs. Financial stability can reduce the need for nursing home placement due to economic reasons. It doesn't necessarily, again, reduce the need for nursing home placement, just generally speaking, but it will reduce the need for nursing home placement due to economic reasons. Enhance education and literacy, promote health literacy and education among older adults to empower them to make informed decisions about their health and well-being. Providing resources and educational programs that focus on financial resources may have difficulty accessing alternative care options or supportive services, leading to a greater reliance on nursing homes. Social support networks, as I indicated earlier, and access to health care are critical to helping to deal with and address social determinants of health. It's important to note that social determinants of health interact with various other factors as well. I indicated many of those factors earlier, such as an individual's health status, their age, and availability of community-based services, to determine the need for nursing home stays and the duration of those stays. So there's an interplay with all of these factors as it relates to whether a person needs nursing home level of care, how long they stay within a nursing facility, and whether they their length of stay in those nursing facilities, whether they die there or not. So this is really a very, very important and pivotal discussion as it relates to social determinants of health in nursing facility. As you can tell and determine based on the information that was shared, we need to continue to collaborate with community organizations and other entities within our communities to support addressing social determinants of health comprehensively. We need to work together to identify local needs, develop interventions, and share resources to create a supportive environment for older adults. And I believe that this will positively impact nursing homes. We need to advocate for policy change, engage in advocacy efforts to influence policy changes at the local, regional, and national levels. These policies can address social determinants of health and prioritize aging in place and promote community-based care options for older adults. And again, I do believe as we look at a system of care across all care areas and environments, that this will positively impact nursing facilities and nursing facility level of care for the individuals who require that care. Thank you very much.